Okay, all right. Well, thank you, everybody. We might just get started. My name's Rita Butera. I'm the Executive Director here at Women's Health Victoria. I'd just like to welcome you here this afternoon to the forum, and just to say also that this forum has been brought to you in partnership with Family Planning Victoria and with the Royal Women's Hospital. So we're actually working together on a number of projects, and this is one of the activities we're doing together. I'd like to begin by acknowledging the traditional custodians of the land, the Wurundjeri people of the Kulin Nation, and extending our respects to elders past and present. Just a few quick words in terms of safe access to abortion. We know it is good public health. It's good public health practice, and it plays a very, very important role in the work that we do with regard to women's health and wellbeing in the state of Victoria. Of course, access and availability of abortion, and in this forum we're talking about medical abortions. We know that access is increasing in Victoria, and it's critical that the changes that have occurred over time in relation to access to abortion are well understood, and I think also for a long time it hasn't been talked about. So I think it's timely for us to start talking about what is important public health for women in the state of Victoria, and abortion is a very important health service for our women in the state. Now, today is actually the first of two forums. There will be two forums on MTOP. Today's forum, we're looking particularly at medical abortions from the perspective of providers. Now, the second forum, which will be held in the second half of 2016, is going to focus more on research. And we just want to acknowledge that some of the researchers and organisations who we're going to hear from at the second forum are with us today, in particular the Centre for Excellence in Research in Rural Sexual Health, SERSH, and also Mari Stokes. I'd like to also just thank everybody who's here today and welcome you. Some have travelled interstate, some from outside in rural parts of Victoria, so welcome you to the forum today. And a thank you to our expert panellists who have given generously of their time and will share their insights. Now, before I hand over to Candy Broad, who will be the facilitator for the session, she will actually introduce you to the panellists, but just to let you know, for people who haven't been here before, we have toilets. The women's toilets are upstairs, outside that door just there. The men's are downstairs. Is that the right way? Yes. Would like to just mention, if you are into social media, if we could just be a little bit sensitive about the use of social media and the discussion. And we have canopies and drinks afterwards, so you're welcome to stay after the session for a short time. Also, we're recording. There is an audio recording of the session so that people can listen to it at other times. I will now introduce Candy Broad. Now, Candy, many of you will know, is a former Victorian government minister and former member for the Northern Victoria in the Victorian Parliament. Candy's also passionate and has been an advocate around sexual reproductive health and prevention of violence for a long time, and we are very fortunate at Women's Health Victoria to have her as a board member. She contributes extensively her experience on issues, as I said, particularly in terms of reform, abortion law reform in 2008. Candy played such an extraordinary role there, and we are very grateful. And also in devising a more integrated government approach to the prevention of family violence, and we can see that some of that work has continued, and with the commitment by our current government to investment of a lot of dollars for prevention of violence against women. So I'd like to welcome Candy.
Thanks, Rita, for your introduction, and welcome to country. Before I introduce our speakers today, let me provide a little context myself. After the Victorian Parliament decriminalised abortion in Victoria statutes so that women and health professionals were no longer at the mercy of common law, that is the interpretation by the courts of Victoria's statutes, I undertook an MP study tour. This is the sort of thing that sometimes brings adverse notoriety to members of Parliament on their study tours, but fortunately not in my case. And the study tour was to examine women and health professionals' experience of medical termination of pregnancy in a number of countries where women have long been able to choose MTOP, including Sweden, where around 85% of abortions before 9 weeks were medical terminations, the Netherlands and England. And this was in anticipation of Victorian women being provided with access to the option of MTOP following decriminalisation. On that study tour, I had the very great privilege of visiting the Karolinska Institute in Stockholm and meeting Christina Hemsel-Danielsson, Professor of Obstetrics and Gynecology and one of the world's leading scientists in reproductive health, contraception and abortion, meeting with general practitioners in the Netherlands who were seeking to define their role in MTOP as distinct from long-established abortion doctors in hospital settings, seeing BPAS in action in a wide range of settings, provision through a community interest company in Hull, not a place that a lot of people go to visit on study tours, and even a chance meeting with James Trussell, Professor at Princeton and founder of the US emergency contraception website nottolate.com, which he supports to this day. I came back with a great sense of optimism about improving access for Victorian women to MTOP, and I expect that our presenters today are optimists as well. Notwithstanding their optimism, my task today is to keep them all to time, so there is an opportunity for interaction after the presentations. And as you listen to the presentations, bear in mind that our ambition is to leave this forum better informed about how increasing availability of medical abortion has affected women's access to sexual and reproductive health care in Victoria. So now let me introduce you to Dr. Patty Moore, well known to most of you I'm sure, a gynaecologist and RANZCOG Fellow. Patty is currently Head of Unit of Abortion and Family Planning Services at the Royal Women's Hospital and Austin Health, and Patty has a long-term interest in young women's sexual and reproductive health and has also worked in these areas in the UK and New Zealand. Over to you, Patty.
Thank you. This is to keep me on time. Thank you very much for the opportunity to speak today. And I want to carry on that note of optimism, as you said, Candy, and answer the question, is early medical abortion increasing access, with a resounding yes. Yes, it is in Victoria. That's been the experience that I've had over the last 3 years. I work in a really big, grey, tall building, hospital, surrounded by concrete in the middle of a city. And what I'm talking about is increasing access for women all across Victoria. But I'm very aware that I'm speaking from the lens of someone who works in a metropolitan service. And I'm very well protected from some of the barriers that other people have when they stand up, put their hand up and say that they will provide abortion services. There's a sort of a code of anonymity around me. And I'm very aware that others are much more braver than I am in the work that they have done, particularly in rural Victoria. So this is quite a personal talk. I know we've only got 10 minutes, so I'm going to, in order to romp through some of the facts, I'm going to do it from my personal point of view, unashamedly, really. So this is a picture of the Women's Hospital, and I put 2013 there because that's when I returned to work in Melbourne and returned to the Royal Women's Hospital as the head of abortion services there. And the emotions I felt within the first 6 months and the fact-finding that I did was that abortion providers, myself included by the time I'd finished the study, abortion providers in Victoria were quite overwhelmed. We were understaffed and we were isolated, but we were also isolating ourselves. And I think that was the most profound thing that I noticed about even my own practice, was that I was, in the ivory tower, and that there were some opportunities that we could embrace. So at the Royal Women's Hospital, we were doing and still are doing 3 abortion lists a week, with 1 Medicare privatised list, so women have a small cost to pay for that. So we were really, in effect, means testing women and providing the service only for the most needy, and for those women with complex medical and social issues, and for those women with advanced gestational age. 35%, so over a third of women coming to the hospital were coming from beyond the metropolitan area, so from beyond the ring road. I used to talk about it's hard to get an abortion if you live outside the ring road. And 50% of those were coming from 2 hours away. And startlingly, I think this was the one that really knocked me for a six, was that there's a big tertiary hospital, Centre of Excellence for Cancer, Centre of Excellence for Maternity Services, complex maternity needs. The single largest reason for women coming to the Royal Women's Hospital was to access abortion. The Pregnancy Advisory Service that I work very closely with, and want to have a shout out to my friends and colleagues in the audience from that group, were and still are really a de facto statewide information and referral service, but not funded as such. So sort of felt like a bit of a problem list. Long wait for long-acting reversible contraception in the community, very limited services beyond the ring road, very limited capacity for public abortion services to meet the demand, and too few providers. And I don't care where I am, I keep on rabbiting on about this, that there needs to be more of us. And I often say in gynae forums when I'm talking to my colleagues, if everybody did their share, this wouldn't be such a big problem. But there's been so much stigma around abortion provision that we still have too few providers. So there's been some opportunities. Abortion law reform provided a huge contextual background for removing some of the barriers for people to become providers and for women to access abortion care. And then along came mifepristone sometime after that. So abortion law reform in 2008. So one of the most liberal abortion laws, I think, in the world, but very slow adoption by Australia of mifepristone. Not great at all. I often joke that my entire obstetric and gynae career has been chasing mifepristone around the world. I went to Glasgow, they didn't get it till I left. And I went to New Zealand, they didn't get it till I left. Now I'm finally in the right place at the right time. But the advantage about that is that Australia has 20 years of data that's very, very reassuring. And so I think, and the tenure of my optimism is that mifepristone is the drug that has come of age now in Australia, and it provides the great opportunity for decentralising services. And we know that we had limited access to it, to mifepristone. We were originally importing it from our friends in New Zealand, and then Marie Stopes, shout out to Marie Stopes, Marie Stopes International became the exclusive provider for mifepristone, and by 2015 had negotiated that it was available under government subsidy for up to 9 weeks. Now that was also another critical barrier being turned over. Prior to that, it was only available up to 7 weeks. And if you can just think for a moment about a woman's journey when she tries to access abortion services, she has to have access a pregnancy test, determine how many weeks she is, then we have to cite the pregnancy. Waiting for ultrasound scans when you live in Benalla, I'm imagining, and have been told is not immediate turnaround. So women weren't getting the service before 7 weeks. Now up to 9 weeks, it's much more possible. And once that clicked over, and that was a huge effort from the drug company to get that through. That made a huge difference. So that really improved our ability to respond. And so here I am working as a doctor in this large metropolitan hospital and aware that we're not meeting the need for those women who are ringing for our service. So what strategies could we do? We could do more abortions, just work harder, get on the treadmill, do more abortions. We worked very hard to streamline our lists. And look, we really increased, over a year, we increased our service by streamlining the lists and overbooking our lists by maybe 200 more abortions a year. A little bit underwhelming, really, not enough to meet the need. And we also then started to introduce early medical abortion. And this is where the blinkers started to go off for me in terms of looking outside of the hospital for ways of decentralising services. So initially we started with small numbers, then we realised it wasn't so scary, that it didn't all have to be in a hospital bed for the whole time. And that really reflects the whole way early medical abortion has been introduced into the world. That initially when a country adopts it, everybody's very conservative, and I know in Glasgow they were all admitted for 2 days initially. Now it's all run by nurse-led unit models through the NHS, and people have a home pregnancy test and they do it themselves. So they've really loosened the medicalisation of it. And the same process happened at the women's. So we initially had really, really rigid protocols. Now we've relaxed to the point where it's an outpatient-based service. But we're still not doing lots and lots of them. And the reason we did them in that model was so that we could teach others to do them, because we don't at this point think that we need to bring patients to the hospital to have this sort of work done. So that was a bit of a cultural change within the hospital to look outside of the hospital. The other cultural changes I just want to mention, because I think they lead really into what Candy was talking about before, about getting access for women. It's a three-pronged approach, really. Instead of abortion services sitting to the side, we wanted them to be integrated and into a general training curriculum for obstetricians and gynecologists, so that it becomes bread and butter O&G, part of what all women's services should be offering, not a shady fringe-dwelling clinic off to the side. And that's been a very important point. Once we established that, we were able then to get more residents and training programs involved. And we have just now got, in cooperation with the Royal College, a training program for a fellow. So to address that lack of providers, we've now got our very first fellow. And we also started to initiate nurse-led provision of early medical abortion. And our nurse unit manager, who's really an advocate for that, Angie Giasli, unfortunately couldn't make it today. And then the other part of the cultural change was to decentralise and look outside of the hospital. So not just thinking about ourselves, but thinking about going elsewhere. And this is where, just to speed along, we had the great fortune at that time to develop a partnership with the Centre for Excellence in Rural and Sexual Health, with Fertility Clinic and Family Planning Victoria. So this to me was like the most amazing lot of partners. It was public and private, it was rural and metropolitan, it was university and hospital-based, it was medical and ancillary counselling services. And together in that partnership we had networking and organisational skills so beautifully provided by surgeons, so essential to the work that we did, medical skills, advocacy and counselling. And we worked on a plan of just really going where we had been invited, was part of the principle, for training of early medical abortion services. And so SERSH did a huge amount of work canvassing people in rural communities about what did they want. Did they want counselling services? Did they want medical-based services? And the answer was they wanted a range of information. And so we provided them, and instead of them coming to the hospital, we went to them. So we got in the car and went up to Benalla and based the curriculum on what they wanted, and had a very good response from the initial training day with about 70 people there. There were school and community nurses, practice nurses, social workers, and even right at the back, in sculpted a medical officer from one of the local hospitals. didn't want his name tagged, but he skulked in, took notes and skulked off, and later contacted us and said he was very impressed. So it was a slow cultural change up in that area. And then we said, who wants us to come back and target it about actually providing early medical abortion? And so we were then, Saoirse in particular, and a big shout out to Kylie there, I can see her, contacting all of those local GPs and local health nurses and saying, no, we're looking at trying to get some models, and some nurse-led models can come to an evening or whatever. And wherever they asked, we tried to go, and Saoirse were brilliant at coordinating this. So we went to Wodonga, Bendigo, Castlemaine, Shepparton, Ballarat, and then repeated another session at Bendigo with some more training things. So a bigger training day, repeating the same initial big model. And then we were asked again to go to Swan Hill, Echuca, and then I went to the Western region, invited by Women's Health West. East Gippsland has invited us, and the Geelong area has started working on this very well as well, and you'll hear more about that as well. So not just us, but it was happening all around Victoria. And the thing was, it was happening without it being forced. It wasn't a protocol, thou shalt deliver early medical abortion because the health department says so, or whatever. It was GPs and practice nurses saying, this makes sense. We've got the reassuring data, let's give it a go. Can you help us? And the things they were wanting were really kind of peer, at the point of peer support. So other people who provided it, telling them what their experience had been like, backup from Marie Stopes if and when it was necessary. It was, I think, the easiest, most organic, sort of flowing set of talks that I've ever been involved in, and an absolute joy to work with those partners. The things that the basic considerations were, the first and most important is that registering, you have to qualify as a prescriber, and only doctors are eligible under the TGA regulations at the moment. And I think there might be some talks about that, because I feel that this could be widened to nurses at some point. Marie Stopes is the sole distributor, and they are the sole training, and they have a fantastic training module for the mifepristone two-step. It's all online. They've got webinars. They have a lot of data that once you have registered you can access and be an ongoing part of their training. They also offer nurse on-call facilities for 24-hour follow-up. So one must register first, and that was initially a bit of a barrier, and encouraging people that registering is not difficult or arduous, and nor does registering mean that you have to carry on and provide. Pharmacists also have to register. But the things that we came up with that seemed to be the constant themes that were being fed back was working on how to source a supplying pharmacist, working on radiology services with rapid response for ultrasound, working on a relationship with a local hospital, and then the actual practice sorting out their own costing. Because one of the other issues of decentralising and embedding early medical abortion in primary care is that the cost could go down. There's a big potential for the cost to go down. And some of the models have ended up developing a model where it's the cost of a prescription, which is absolutely fantastic, and everything else is bulk billed. And whatever way they were going to advertise their service. So some areas wanted to advertise their service explicitly, and there's a group in Wodonga that sent out flyers and told other GPs that they would run this service, while others only wanted to look after their own patients, so patients they knew that they would see and see again for follow-up. And those were all local responses to local issues. And what we discovered was we didn't have a prescription, but we got told from each area their own solution within time. And so there have been many solutions developed. There are some where the GP herself, who trained in Scotland, does her own ultrasounds on the spot. There are other options where The ultrasound colleague is across the road from the sexual health clinic and leaves a space or two on the end of his Thursday list to do dating scans. There are others where someone will bulk bill. There are other models where a GP will travel from one place to another to provide the abortions. And the other thing that was just overwhelmingly obvious to me, that was when nurses took over organising, it actually happened. Absolute epiphany for me as a doctor. And there's one who I just love to this day. She's the bossiest practice nurse I've ever met, and she was fantastic. She basically said, right, you and you are doing it next week. I've set out this time, I've cancelled your patients. You're going online, you're getting the webinar, you've got one chance to get it. And then she started booking patients in. And it happened. You know, talk about understanding procrastination. And that group has been particularly reiterative in, I think she's moved on, but then another person has taken her place. And some of the GPs have moved on. Now, obviously, we have to evaluate, is this working? And this is where SEARCH has really taken the lead as well. So the SEARCH is, and they'll talk about this later, I'm sure, later in the year, about how they're going to evaluate qualitatively and quantitatively. Has the strategy of decentralising and setting up little groups, cell groups, if you like, has that worked, and has it translated into people becoming prescribers? It's all very well to say the model appears to work and it was fun to do, but we need to know that it has worked. And I'm sure there'll be more on that later in the year. But as of this stage, I really love this function where you just press it and it goes, that's great. So it's looking better and better. I wanted to have little light bulbs going on, but I didn't have the technology to work it out. But it's really spreading, and obviously the Gippsland area and up around Horsham, etc., are areas we're waiting to be invited to, and areas where I know that family planning is putting special effort into. So the other thing that, just before I end, I noticed about rural Victoria, not being from Victoria, you might have picked that, was how competitive each of the little centres are. It's like sort of footy, you know? And if you said, oh, look, in Castlemaine they've started, they go, who started in Castlemaine? Oh, she started. How many has she done? And so if you could start sort of dropping hints that people had started, it set off like wildfire. So the other thing I learned about rural Victoria is how far away everything is. Halfway through the year when I was doing a lot of these trips, I broke my arm and had to go by the train. And I really understood how far we were asking our patients to travel to really early appointments. So just future efforts, obviously we need to evaluate. The big thing that I want to say is to encourage more groups to share their models in local forums, share the positive experience from it. We know that it's safe. We're going to hear about telehealth opportunities today. I think that's another model that's fantastic. I want to continue to champion and shout out about the nurse-led models of care, and perhaps work on advocacy for nurses to be able to provide the medication. Lots of opportunity for peer support and education sessions, web-based, local buddy systems seem to work really well. There's a woman who prescribes in Ballarat who's going to be press ganged by us to go on a webinar and tell aren't we, Kylie? We're going to press gang her, the lady from Ballarat. We're going to make her go on a little webinar and explain how good it is and how easy it is to prescribe. And coming from her, it's going to be more powerful than coming from the physician in the big grey hospital. And finally, sharing models at forums such as this and in other states. So again, I just wanted to end on a really positive note that I think it's not the panacea for everybody. It's not all women should have an early medical abortion. It's a choice, but it provides a great opportunity for rural and remote women, and that's what we've been talking about today. So thank you very much for your attention. I look forward to hearing from the others.
Thank you very much, Patty. As someone who remembers, and I'm sure many of you in the room do, the opening of the new women's hospital. I'm not sure everyone would be thrilled about your description of it, given the amount of money that it cost.
Have you seen the new cancer hospital?
Yes, that too. But I think we all understand what you mean. So can I now introduce Dr. Suzy Allanson? Suzy is a clinical psychologist at Melbourne's Fertility Control Clinic, with more than 25 years of experience providing support to women. And the Fertility Control Clinic, for those of you who don't know the history, was established in the early 1970s by prominent abortion campaigner Dr. Bertram Weiner, with lots of support with our treasure Jo Weiner. And another big shout out to the Fertility Control Clinic and to Suzy and the team. In 2015, Suzy and the Fertility Control Clinic played a key role in successfully advocating for the introduction of safe access zones legislation in Victoria. A wonderful achievement. So Suzy, up you come.
Now, I also have gone the more personal way with this. Might not be quite as optimistic as Paddy, but few people are. Now, I just want to be clear too that in contrast to the public system, I'm from a freestanding metropolitan Melbourne-based private clinic, and as Candy said, I'm a clinical psychologist. I do have a PhD, but I'm not a medical doctor, although in the media you might have heard that it's Suzy Allanson's clinic, but it isn't. And I'm not a partner in the practice. I work sessionally there. I'm very proud of the work that the clinic does, though. Now, I'd like to describe from my viewpoint the introduction of MTOP, and it might kind of flesh out a little bit of that scariness that you were referring to in a different way from the medicos, perhaps. And then talk a little bit about the MTOP experience at the clinic and also this issue of cost. Now, we welcomed the Therapeutic Goods and Administration registration of mifepristone in 2011, I think it was, and we all thought about time. And we knew that, I think it had been originally held up by Tony Abbott at one stage, hadn't it? So it had this long, muddy history with lots of frustrations, but not as many frustrations as Paddy's had with chasing around mifepristone. Now, in that year, the clinic attained its TGA prescriber authority, and it was a lengthy and detailed process. And thank goodness we had a pretty obsessive scientist from our pathology lab that really did some terrific work with that. It was just so detailed. Like many, we sourced mifepristone from New Zealand, and the cost of that was $60 per tablet. A year later, in I think it was November 2012, don't quote me on the dates, the TGA registered mifepristone by sponsor, and the sponsor is Marie Stopes. And Marie Stopes have worked very hard to secure this, and I don't have a clue about all the work that they've put in around medical termination and the medication required. By March 2013, the clinic and other MTOP private providers were no longer legally allowed to purchase the medication from another source. We were legally obliged to purchase it from Marie Stopes. Now, the cost of the New Zealand tablet, $60, and at that stage the cost from MS per tablet was $320. So in real terms, it meant that during 2013, very few medical terminations were being performed in the private sector, apart from MS, I think. So we knew that Marie Stopes was working towards a PBS listing, and we thought, well, this can't come soon enough. But when or if it would actually happen was a bit of a moot point. So it was quite worrying. And most of the private abortion providers were quite worried during that 2013. We were also concerned about the unusual TGA sponsor agreement. MS is the exclusive supplier, exclusive trainer of the health practitioners, exclusive gatekeeper of competency, exclusive lister of the MTOP providers to the public, I think that I've got that right, and is an abortion provider itself. And so although that may mean that it enhances coordination and it works well, I guess we also had concerns that it might produce conflicts of interest, which potentially might compromise women's health care. We were also concerned at the time that there was talk that coming from a comprehensive abortion and sexual reproductive health service was lacking a focus on best practice. And some of Marie Stopes' marketing sort of fed the idea that medical abortion, you pop a pill and somehow while you're reclining on your white sofa with the kittens around the place, you magically become unpregnant. So at that stage we had concerns sort of around that as well. So we actually were advocating with appropriate authorities, people, trying to ensure that best practice was at the top of the list in terms of the MTOP training and provision. Now, with the training, that's a huge issue, which you've obviously been doing a lot of work on, Patty, thank goodness. And at that stage, we were thinking, oh, surely the ONG diploma in family planning even could incorporate much more in terms of surgical abortion and medical abortion. We were concerned, and we have been for a while, that gynecologists don't find it challenging enough, or because they won't do their bit, if you like. And so we were thinking that perhaps GPs could be a good target. Now, by November 2013, the PBS listing was secured by Marie Stopes. So now we taxpayers foot that bill primarily, and everyone heaved a sigh of relief. And MTOP provision began in earnest then, I think. Now I've got here, or could it, with a question mark, because we're probably the abortion provider in Australia with the greatest longevity. I'm not sure on that, but we must be up there. And we'd found the whole process really onerous and worrying. And at times we'd considered whether MTOP was really worth it. And so if we'd done that with all our resources, we thought, well, I guess there might be plenty others in more mainstream, regionally, who would look at this and go, no, too hard. Now, our experience of MTOP provision, it's been fortunate to have a practice manager who, as you were speaking about that nurse, I thought that sounds like Janice, our practice manager. And Janice Nugent was determined and passionate about getting the MTOP up and running. And we also had our pathology scientist whose continuing attention to detail was really most helpful. And they ran with this to ensure a proper best practice MTOP process and care for our patients. And yes, so the individual staff, not necessarily the doctors, were key in setting up the MTOP program. In general, we found that providing women with realistic MTOP expectations and pain management is crucial in ensuring patient satisfaction. Accurate information about MTOP and surgical abortion allows women to choose what they believe suits them best, bearing in mind any medical exclusion criteria. And of course, but not at all a minor consideration, if women are to have this choice, they must not be delayed in accessing care. And a range of barriers still exist, and too many to go in today, but the regional is a major one, and we did a little pilot study which just highlighted that. It was a bit scary, really, so go Patty and Serge. In terms of the cost, the hope had been that MTOP would cost much less, and the cost at the Fertility Control Clinic is really only slightly less than for surgical abortion. And while, surgical abortion's 99% effective, MTOP has a roughly 6% failure rate, and then requiring a surgical abortion. So at the clinic, we provide that at no cost if that occurs. I don't fully understand the costs and the reasons for the costs. I do know that there's different bulk billing rebates and processes applying to inpatients versus outpatients, and there's no MTOP Medicare item. I think Murray Stopes is relatively expensive too. And like most people, I want to see that cost reduced, and I think this will occur. The regional providers are making a wonderful impact, and with some providing MTOP with no out-of-pocket costs. And I think there are people here from, is it Wodonga Gateway? And I think they've done some really, oh, hi Kylie. And I think they've done some really fabulous stuff. And that will feed back to clinics like the Fertility Control Clinic. And so we will, I'm sure, be making it more cost and affordable for women. And the family planning, your recent service, I think, is with low or no cost to patients. So I'm not up with it all as yet. And I'm not sure what you'll be doing when MTOP fails and the things. But I really think with the entrance of more providers, with the work that Patty and Saoirse have been doing, we will see it the way we want it to be. Now, so the extraordinarily onerous work and worry of MTOP introduction is in the past, and this may be my own little debrief to get it in the past, and women shouldn't have to continue to pay for that sort of rocky start, if you like, and practitioners should feel more confident in their role providing MTOP within best practice standards and networks of care. Thank you.
Thank you, Suzy. I'm with you on cost. I can't tell you how exciting it was to see BPAS in action and know that contraception and terminations were free.
Yes.
And what a tremendous difference that makes in a health system when that level of provision is there. We're a long way from that.
We're getting there though.
That's a matter of
Optimism.
That's a matter of government policy,
yes,
which affects every one of us. So thank you, Suzy. Now, I'd now like to introduce Dr. Paul Highland. Paul is an obstetrician and gynaecologist based in Launceston. Paul is the founder and medical director of the Tabit Foundation, which was established to provide an Australia-wide telephone consultation home medical termination of pregnancy service. That's quite a mouthful. Paul has particular interest and expertise in increasing access to abortion with telemedicine, and we are particularly grateful to Paul for travelling to be with us today. I initially thought that meant from Launceston, but I understand in fact he's come back very recently from New York and meetings that touch on our subject matter today. So thank you very much, Paul. Over to you.
Well, thank you very much for inviting me to this first meeting on medical abortion and women's health Victoria. Last week I spoke at the 18th meeting in New York on mifepristone, so we have a long way to go. There they gave us a map of mifepristone approval in the world, and I made some copies, and which I wanted to share with you, showing the years that mifepristone has been available in different countries. Why has it taken so long? And just to put you in perspective, it was in 1995 or 6 that Right to Life Senator Brian Harradine, independent from Tasmania, agreed to John Howard's proposition to privatise Telstra on the proviso that mifepristone was not made available in Australia. And it was John Howard's Minister of Health, Tony Abbott, who saw to that, and subsequently as Prime Minister continued that policy until vetoed by his own party in 2006, under intense pressure from academics and others to allow its use, yet on a very restricted basis. But it was not until Rudd's Minister of Health, Tanya Plibersek, put it on the PBS, that it became readily available. However, Plibersek's dream of it being available for $12 really has not become reality, because abortion providers charged the same or indeed more than the surgical procedure. Last year in October, we launched the Tablet Foundation to provide a home-based, direct-to-patient medical abortion service. Being a first in the world, we provide medical abortion to women in all states apart from Northern Territory and South Australia, to regional and remote areas where no access to abortion previously existed, for $250 inclusive of all medications. The three largest insurers of professional medical indemnity, it's Avon, MDA National and MIPS, now insure our doctors with no increased premium. How do we do it? Well, about 50% of our patients are referred either from general practitioners or centres or sexual health or family planning or Aboriginal health or Link or Headspace, various sources, and others from the web. We screen our patients' acceptability before arranging haematology and ultrasound from the most convenient provider. These results are then sent to our doctors, either a specialist gynaecologist or general practitioners credentialed in MTOP, for a telephone consultation with the patient. MTOP is probably the most applicable medical service that can be provided by telephone because physical examination is not necessary. And contraindications to medical termination of pregnancy are revealed by the medical history. If the patient is found to be unsuitable, then of course we don't proceed. But if suitable, we then express mail all the medications that are required, not just mifepristone and misoprostol, but analgesics, antibiotics and antiemetics, in all about $100 worth of drugs. Patients have a 1-800 number to call 24 hours if there's any queries or problems, answered by a doctor, not a nurse, but our nursing staff do contact the patient on the evening of the abortion to make sure of their well-being. 10 days later, the patient has a second beta-HCG, which is compared with one which is done prior to the abortion, looking for an 80% fall. We have now registered over 850 patients in 8 months. Victoria accounts for about 20%, so it's rather population-based. And we have about a 3 or 4% intervention rate with about a 2% or so failure rate. The trend to medical abortion worldwide is undeniable, and we must embrace that change. Nearly all abortions in Norway are done medically. As you heard, 80 or more % in Sweden, and indeed Scotland, are done medically. England, 48%. In USA, it was announced by Planned Parenthood last week, 46%, which is twice what it was in 2013. The biggest problem we now face in this country is education. That MTOP is not an alternative, but it's preferable to surgical. And we need to inform women, and in particular teenagers, that early intervention, if the pregnancy is unwanted, will result in a delayed heavy period. There are a number of things we need to do to achieve this. Firstly, acceptability, by reducing pain and bleeding. Of concern is that if this is not adequately addressed, medical termination will be poorly perceived. Secondly, accessibility, by minimising the process as much as possible by still maintaining best medical practice. We provide this service in remote and rural areas if the patient's within 60 minutes of a medical facility, but access for ultrasound and anti-D, if the patient's negative, is sometimes problematic. Thirdly, affordability. Medicare item numbers for telephone consultation will reduce the cost to the patient, and we are at present making submissions for these numbers. My ultimate aim is to convert the Tabit Foundation to a charity and provide medical termination freely to all women in Australia. Finally, we need to be adaptable. Surgical providers must face reality of a change to their business model. In Tasmania, after we introduced medical termination, our surgical numbers declined to such an extent that we were forced to close our Launceston Centre. This was good news. And this is going to happen elsewhere in Australia. Similar concerns were raised at the meeting in New York, where it's already been noted as a feature in the United States. Mid-trimester abortion by surgery will be entirely replaced by medical in the near future. Surgeons with this expertise to do mid-trimester surgical abortions are becoming fewer by the day. And these days are numbered for abortion providers providing the service. Adequate provision of early medical abortion will reduce the number of patients, and now FDA has approved Mifeprex, which is MS two-step in USA, to 10 weeks, and no doubt MS Health will apply for this in this country. So this will further make the surgical procedure uneconomical. I see mid-trimester abortion being provided in the future in centres of expertise, because there'll be so few of them, as a day-only procedure, as they do in UK, in a designated public facility. Thank you.
Thank you very much, Paul. It was very instructive seeing that map for those of you who haven't seen it. The one which is the most recent to be added to the list is Canada, which I must say I was not aware that it had taken so long in Canada. So, thank you again, Paul. I'd now like to introduce Dr. Cathy Mcnamee, Medical Director at Family Planning Victoria, a leading and long-standing not-for-profit statewide provider of sexual and reproductive health care education and advocacy. Family Planning Victoria services include clinical care, education and training to help build the capacity of educators and healthcare professionals working in the sexual and reproductive health sector. And can I just add that Family Planning Victoria has recently become a provider of medical abortion. The board of Family Planning Victoria, the board of Women's Health Victoria, was very fortunate at our annual planning day not so long back to have a presentation from the former CEO of Family Planning Victoria, Lynn Jordan, on the journey that family planning has been on to become a provider of medical abortion. And we were very privileged to hear that presentation, and I expect we're going to hear a bit more about it today from Cathy. So over to you.
So thank you very much for the invitation to come and talk. Actually, sorry, just before I start, I just wanted to say I had follow-up with one of Paul's patients from the Tabit Foundation recently. She came to family planning for contraception, and she just really liked the privacy of the whole experience and the convenience of it. So, it was really lovely to see someone and get that feedback. So the background at family planning, a very long time in the making for family planning. It actually took us a couple of years from when we first started to think about medication termination to when we actually did it. There was a lot of concern about how staff would feel about it. Although family planning is a pro-choice organisation, I think there's sort of been this feel that in organisations like that actually we don't call it counselling. We give pregnancy choices information. People can book in with a nurse to get information about their pregnancy choices options. That we should be sort of separate because there would be sort of a conflict of interest in some way. But in some ways it was very good that it took so long, because by the time we were ready, all the staff were really on board, and people that we were concerned about were actually asking if they could be part of the process in delivering the services. We had a very supportive CEO, excellent board support. Patty's actually on our board. And we also had fantastic support from other professionals, a number of them who are in the room. Lauren from Clinic 35 and some of the other doctors in that northern sort of area were very supportive in sharing their information. You know, people from Interstate, Mari Stokes, Fertility Control, people were very keen. And any time I've had a problem, it's been very easy to pick up the phone and call someone. I suppose one of the reasons that we wanted to do it, we've only done about 70 or 80 so far. It's a fairly small impact, but we really wanted to fly the flag. And I was looking for flag flying pictures this morning, and first of all I got about 100 of the United States. But then I put flag flying abortion rights, and they were nearly all about anti-abortion, and some horrible pictures, you know, ones with women with a gun to their sort of pregnant abdomen and all sorts of things like that. Because as Patty says, and I have the same problem pronouncing this word, we're anonymous there, you know, we're not, no one knows who we are. And I found, we've been doing some talks in the rural areas, and I found this is a big thing. That people know there isn't a doctor, but the doctor doesn't, and I think it's fine. The doctor doesn't actually want to be identified. It's just a local sort of word of mouth thing. And I know Mari Stokes and us and a couple of other organisations put quite a bit of work into perhaps looking at whether we could have a service provider list, but it's just not something that's really possible because of the feelings around it. So we have a cost recovery model. We would love to bulk bill everyone, but we are able to bulk bill 1 in 4 healthcare card holders. But in fact, our figures are about 40% healthcare card holders. We usually take those on as extras in the clinic. So we thought that we would have a very neat model and for some reason my Eastern Health has come across. This little thing was supposed to go around Eastern Health here, where we had a memorandum of understanding with Box Hill Hospital and the Anglers, and we were just going to advertise to local GPs, and we thought we might have a nice model where we had this local sort of model of care and the relationship with the O&Gs. but we just sat there and we didn't get any referrals. So, and our first referral came, we were really excited, and she didn't turn up. And then, it took a while to get going, and we quickly realised that wasn't going to work. So we just started taking referrals from anywhere, and we've had them as far as Wonthaggi, Kilmore, lots from Craigieburn. So as a lot of you would know, women are very prepared to travel to get an abortion. I think some sort of MOU with a local hospital is important if you're setting up, or not even an MOU, but some understanding. It's not the acute care, because we've actually found the one hospital that no one's been to who's needed acute care is Box Hill Hospital. We've had people go to Monash, people go to Casey Hospital, and they've all had really good care. The hospitals are actually bound to look after the women. They can't actually refuse them treatment, or to find somewhere that will actually give them treatment. But it's more about if the procedure doesn't work, and someone who will actually do, or if they've actually, the pregnancy is gone, but they've still got retained products and they need a non-acute surgical procedure, and we haven't actually come across that yet. So we wanted to do it as a one-stop shop because we thought that would be as diverse as Ferntree Gully, which is fairly far from us, or Healesville, but much more diverse as it ended up being. So we were very keen to have it as a one-stop shop, and I don't think that's generally achievable in most primary care settings. We were able to buy an ultrasound, but that's quite useful for IUD training, so we had sort of a reasonable justification of buying that. So the women actually ring up, they have a phone consult with the nurse, they're given linked protected information if it seems like it's a suitable thing, and then they come in for a single visit. Some of the difficulties we thought that we would encounter if we tried to get the ultrasounds and things done beforehand was the difficulty getting a pregnancy-related bulk billed ultrasound in Melbourne. Like, it's usually about $100 out of pocket, even from the places that normally bulk bill. The difficulties that we faced were women with very early gestations, and that's one of the things that I learned, that 6 weeks, most of the time they're about 5 when they, not most of the time, but it's never 6 when it's 6 from their dates. And we've had a very steep learning curve with using the ultrasound, and we had a few coming in that were just a sac. You can't actually see the fetus in it, and we have developed a protocol, particularly with assistance from others, about going ahead with this, because it's very difficult if someone comes from Kilmore, and then you have to tell her to go back and come back again another day to have the procedure. We've had a few things coming up on the phone, like people who are planning to hop on an international flight the week after. One poor woman was actually living in a tent, and she was planning to have a medication termination. We've had a few women who felt that they could probably have the miscarriage at home but not tell anyone about it, like one didn't want her partner to know. So it's really made us sort of think about really making sure that the women are aware of the surgical option, because some of them were coming through and they really, I think, would have been much better served by a surgical termination. I think it's very hard to get across what they're in for, because it's a huge breadth of experience. You don't want to scare women, but we have had a few women say it's the worst pain I've ever had, women who've had vaginal deliveries. Most women it's not, they cope with it very well, but you do need to give the women some idea of what the range of experiences is. One of the things that we had initially, we started off with the nurse doing the consult, but we found we were doubling up a lot, because to sign off the consent form, I sort of feel that I have to give the information and be sure that the woman has understood it. So I now see the patient first, and the nurse sees the patient and then asks them how they're going to do it and how they're going to go about to see if she's actually understood what we've spoken about, and does the contraceptive consult. Although we do have to charge, we don't actually charge an administration fee, which we'd normally charge, and we don't charge an extra fee for IUDs, which we'd normally charge if they don't have a healthcare card. So some of the learnings that I've had, they're mostly personal sort of learnings. I feel that the stigma for women presenting for abortion seems to have decreased over the years. I feel women aren't as sort of, a lot of them are quite fine with the fact that they're coming in for an abortion. It's not something they feel that they have to feel bad about. It's been a very positive experience for our staff, which was a bit of surprise for me. because it is very nice feeling that you're able to give women good care in a time when that's actually difficult for them. We've had very good success at selling IUDs. We really try and bend over backwards to get them in for an IUD at a time that suits them. But we've had very poor success at getting implant-ons. And I know the women's are planning to do implant-ons at the time of the first tablet, and that's something that we'll look at through our clinical governance. Other problems that I've had is that there is, as you're probably aware, a pregnancy-related counselling item, but it's very hard to find practitioners. The women can go to their GP and get a mental health care plan. This is for a very small minority of women, but we have had a few women who have wanted a little bit of counselling or assistance afterwards, so it's just an extra step of having to go in and see the GP and explain what's going on. So if anyone's aware of people doing it other than in Croydon, I'd be really pleased to know. I mentioned the hospitals the women have presented to acutely have really done an excellent job. It's usually about pain management, and I think that was your point, Paul. I'd be really interested to see what you actually give them for pain in your packs. The Dr. Murray helpline has been fantastic for patients. You know, we felt very confident with the line that women can ring after hours. And I suppose the last thing I want to say is something along the lines of what Suzy said. I'm too old to be needing to thinking about an abortion now. But if I were, I probably would actually have a surgical abortion now. I think medication abortion is fantastic, and it's fantastic, for increasing access. But it is a little bit more messy than surgical abortion. It's just a little bit more uncertain, and I would probably just prefer to go in my appointment and have it finished. So that's all I had to say. Thank you, I think. Oh, sorry, where to from here? We've just been continuously refining our model, particularly the paperwork. We really want to make it available to GPs. We want to add in a model of seeing clients with external ultrasound and rhesus at an adolescent, because we've only got the one adolescent clinic in the city, and we're very keen to support primary care with paperwork, or with people sitting in our clinics to learning information about the procedures. It's interesting. It's very scary before you start, and once you start, you realise that actually someone else manages most of the scary stuff. Usually, it's usually the hospitals who manage the more scary stuff. I mean, we take phone calls about it, and we make decisions, but it's actually very straightforward. That is all. Thank you. Yes.
What do you mean by the scary stuff?
I think people, I know practitioners are sort of, I personally felt very anxious, particularly to start, about what it was going to be like, sort of handling the bleeding, different things along those lines. But the reality is I really just mostly handle giving the information about it, and that's actually very straightforward, and, sorting out with the woman whether she's got any contraindications or things.
What do you charge?
We charge, it's out of pocket, it's $215, and it's bulk billed for the healthcare card holders, most of them.
Thanks, Cathy. I'm sure there'll be lots of follow-ups, and I think that was an interesting reminder, an important reminder that at the end of the day it is about choice for women, and by increasing choices we increase access. So I'd now like to introduce Dr. Angela Rutherford, GP Clinical Editor with the Health Pathways Melbourne project of the Melbourne Primary Care Network. Health Pathways Melbourne is an online portal designed to be used by general practitioners to guide best practice assessment and management of common medical conditions. Over to you, Angela.
Thanks.
Good evening. That one? So, very interesting to listen to the other speakers, and I'm particularly looking forward to hearing from Lou next. But I'm just presenting to you a project that's operating quite broadly across the state now, which is going to be is an avenue for disseminating information to primary care practitioners, particularly GPs, and facilitating referral pathways. And we have a segment specifically related to MTOP, which I'll get to in a minute. Just on the the broad pathways. Some of you may be aware, but it's a website with accurate, relevant, best practice information on common clinical conditions. Particularly relevant is including referral guidance. Obviously, we try to be up to date. Every pathway is reviewed every 2 years, and it's written by a small group of us who are GP clinical editors, and but the content is largely developed by hospital specialists and other subject matter experts. And Patty, thank you, Patty, was a subject matter expert on the medical termination pathway. So nationally, there are around Australian sites that are implementing health pathways. The Melbourne Primary Care Network is only one of those. We're all independent. The website itself is managed by a New Zealand company called Streamliners, and but there's a lot of behind-the-scenes sharing of content, so we're not all trying to reinvent the wheel. And in Victoria, 5 out of the 6 primary health networks are working on this project. So they're our current partners. So I think I'll just skip over that. And we've got a lot of work's been completed, and so over 300 pathways, nearly 200,000 page views. So it's gaining momentum. So when we put together a pathway on termination of pregnancy, the aims of the pathway were to support GPs who are providing termination advice and or management, and the pathway was completed just 6 months ago and launched. There is an evaluation process for the whole Health Pathways program. That's still being developed, so I can't, while I can tell you that we have page hits, I can't tell you how, much impact they're having, but that's in process. So this is a snapshot of what a Health Pathways opening page looks like. I've highlighted on the top left the search function. You also see a sort of tree structure with gynecology opened up, showing all the pathways that have been that are available under that heading, and termination of pregnancy is down there. So I'm just going to show you what the process is like for users of the pathway. It's quite detailed, and we do aim to have pathways as compact and well presented as possible. And when I prepared this, I thought, could be able to do this a bit better. But down the page, you'll see we have a management option for a patient with a positive pregnancy test who's going to choose abortion, and under that heading we have a link to a detailed section on medical abortion, and there it is. And I've highlighted that with a couple of arrows the links to the online training. So that's that's a lot of information, but it means that for GPs who are not providers of medical termination, this is a comprehensive site where they can at least find out about it. I've been making notes during the other speakers' presentations, and thinking that I'd like to add in some other contextual data, such as the high proportion of MTOPs that are being done in other places, and feedback from what's been missing in our development of this work, and in some of the presentations we've heard so far is, except for Cathy's comment about the patient who came back, is the patient's feedback. Because certainly in general practice, a patient whose friend has had an implant on is a far higher recommendation than half an hour's yarning by the GP. So patient feedback is important. And when I prepared this, I thought I'll speak to my colleagues at East Brunswick Medical Centre. There's about half a dozen doctors there, and interestingly, almost all their comments have already been touched on by the previous speakers. So over half a dozen doctors, the points that came out of a discussion were these: that overall the clinic, the doctors thought that we had a small number of requests for termination, and the estimate, which I thought was surprisingly low, was only approximately 6 a year across the whole practice. which made the doctors think that any one of them was unlikely enough to get enough experience to feel competent. And, it may be that quite a number of our patients are accessing an online service or going somewhere and not telling us. Several of the doctors weren't keen to see new patients specifically for MTOP, and this speaks to the advertising and promotion side of it, and they would prefer to manage in the context of ongoing GP care. One GP had reported through another clinic she'd had 2 patients who had what she's deemed very, unpleasant complications, incomplete abortion or a lot of pain. So I think, these kind of experiences clearly need to be put in context. A couple of the doctors felt that they believed that patients just want an anaesthetic to have it's over. So I was interested in your view on surgical termination, Cathy. A very practical issue for a group practice of, community-based inner-urban GPs is how is follow-up going to be managed with mostly part-time practitioners, and the remuneration, we had no idea what it would be and would it be adequate, and so it was, in that context, quite a big challenge for GPs in a kind of a small inner-urban practice. So it's very important, I think, for this discussion to move towards the other modes of delivery of the service. Thank you.
Thank you very much, Angela. I think we've all had experiences of lack of integration of healthcare in GP clinics in all sorts of ways and areas of healthcare. Can I then introduce, as our last but not least presentation, Dr. Lou Sanderson, the Clinical Director of Cardinia Health. Lou has worked as a general practitioner in the Belmont area since 1988. She's been involved in vocational training for general practice since 2004 and has worked as a medical educator with GP registrars and with the Deacon's School of Medicine. Lou has also worked as the regional training provider for GPs in her region. Over to you, Lou.
Thank you. So which button is it? Yeah, okay, great. Thank you for inviting me to speak today. I was involved in women's health politics back in the 80s, and I used to work as a receptionist for Family Planning Victoria when it was in Richmond. So it's really nice being back. I went down to Geelong as an intern in 1985. And it's been great being a GP in one area for a long period of time because the continuity of care is fantastic. Back in 2009, we were very fortunate to get GP Superclinic funding for a big clinic called Cardinia Health. We've been open for nearly 6 years now, and I've been clinical director there. Cardinia Health's a big 26 consulting room clinic. We've got about 14 GPs, we've got a multidisciplinary team, we've got a big nurse treatment room, we have a sexual health clinic. About 6 of us do IUD insertions. So we're a general practice, but with lots of areas of special interest, and I'm sort of trying very hard to keep us upskilling, particularly in the area of women's health. So from the storytelling point of view, back in about 2012, a group of us went up to Family Planning Victoria and did the training course to insert IUDs. After I'd done about 100, I said to Cathy, can we start training local doctors, because I'm just getting too many referrals and I don't want to only do IUD insertions in my practice. So since then, we've been doing the practical component of the training in our clinic, and we've now trained about 18 doctors to do IUD insertions. So they're doctors from around Geelong, they're GP registrars, but they're also, there's now people coming from, one from Ballarat, Werribee, there's been some interest from Warrnambool. So that's been fantastic. And in a way I can see a similar thing happening with the medical terminations of pregnancy, because again, the last few weeks I think I've sort of almost seen one a day. So So this is a side view of our clinic. As I said, it's a big clinic. So I want to jump straight to what has helped us to provide medical terminations of pregnancy in a primary care setting. And I agree with Angela, there's certainly some challenges, but a lot of those I think have been quite quickly overcome. 4 of our GPs have trained to provide medical terminations of pregnancy. One of them's now on maternity leave, but I've got 2 more coming on board in the next few months, which is great. So some of the things that have helped to make it work. One is having long appointments available on the day or on the following day. So when I started doing it at the start of 2015, I decided that I would have a half-hour appointment at the end of each day only to be booked for a medical termination of pregnancy. If it wasn't taken on, by midday, I just get to see a couple of sick kids at the end of the day. That's fine. So that's not an issue. We have a pharmacy on site who are a registered provider and a very sort of sympathetic and supportive pharmacist. We've put in place the paperwork that makes it easier, and I'll show you some of that because as clinical director, I guess I've been very committed to putting in place efficient processes with all of our clinical services. And we can do that with technology. We can create templates that are easy to populate and give people individualised paperwork, which has been, I think, really helpful for the patient and the doctors. We give them a letter to the emergency department. The support from MS Health has been really vital, and I think it would have been very challenging to take this on if we didn't have that 24-hour nurse line. So I think that's a really critical support that we know we can give the patient a phone number that they can ring any time. Yes, we have an after-hours service that we provide, but there's going to be a lot of people on call who are not experienced in managing medical terminations of pregnancy. We happen to have an ultrasound in our clinic, and we bought it for the physios when we set up. When I was doing the IUD insertions, I thought, I might learn to use this. This could be handy for my IUD insertions. So I went off and did a course. And then with the medical terminations, also having the ultrasound on site. So I went and did another course, just a day refresher. 3 of our other GPs came up with me. So we can date pregnancies, probably 1 in 10 I would refer for an external ultrasound, but I can happily date the pregnancy, so we can do it as a one-stop shop. And I really enjoy that skill, I guess, and upskilling in that way. We've got on-site pathology as well. The support from the local gynecologists has been really important, the support from the emergency department, having the clear protocols set out from MS Health, and we have anti-D available on site. So all of those things help to streamline the process. The sort of numbers we've had, we've been getting increasingly referrals from GPs in the area. We don't have a sign out the front saying medical termination of pregnancy available here, but word of mouth is sort of gradually spreading around the area. GPs are sending people in. The Choices Clinic at our local hospital is also sending people to us, particularly when they can't get them in for a couple of weeks, and because we can usually get them an appointment within a couple of days. We've done 75 at this stage. 8 have proceeded to D&C, 1 has required a blood transfusion. But I think in the very clear consenting process and the providing information for women, they know that there's a percentage that won't work. They know that there's a percentage who will need to go to the hospital, and we give them the letter. So it's all very clear and well outlined that there could be these complications. And I think it's only when complications occur that women aren't informed about that there is more issues, I guess, with women coping with that, like, perforations with IUDs. If women are well informed about that, it's an informed risk that they're prepared to take. Our protocol, we sort of have a 30 to 45 minute appointment. I like to be able to do it all in the one session. I'll explain to the woman if I can't, if there's a good reason why I can't do it all in one session. We have a checklist, so we can sort of run through all the appropriate history. We counsel regarding the pregnancy, we explain the MTOP, we do consent. It's often quite difficult just working out the timing of the procedure, and I insist that they have a support person with them for the 24 hours after taking the misoprostol. So just working out timing with work rosters, etc., can be a little bit difficult. The ultrasound, if we confirm that it's a pregnancy, that we can proceed with the medical termination. We make sure that we've got the blood tests. We provide with there's a lot of paperwork. We provide with the leaflets, a personal schedule, the letter to ED, the prescriptions, the pathology follow-up and the follow-up appointment. They go down to the pharmacy, often while I'm doing the paperwork. I send them off down, do the scripts, send them off down the corridor to the pharmacy, come back and I've printed up their paperwork, so I'm not just sitting there typing. We review in 7 days for the same reason as Paul outlined, and I take a phone number for their support person so that if they don't turn up for their follow-up appointment and I can't contact them, at least I've got another chance of finding someone who knows where they are. Of the 70 we've done, there was one that ended up proceeding to a mid-trimester termination because she missed the follow-up appointment, couldn't be contacted, and ended up presenting with a 16-week pregnancy to the gynaecologists, unfortunately. So we've added in that step of making sure that we've got another phone number. Our one-pager is our schedule that we give to the patient in addition to the leaflet. This just talks through the things that we're going to cover in each appointment, and we fill in through our sort of template in our software, we fill in the time to take each drug. We fill in the date of the appointment and which doctor it will be with. And at the bottom there, even though it's in small print, we have the contacts for our own service, the MS Health 24-hour phone number and the public hospital phone number. That's it from me.
Excuse me, what do you charge?
Oh, sorry, I forgot all through. I've been thinking. Our clinic bulk bills healthcare card holders, pensioners and under 16-year-olds. I apply that same billing policy to the people I see for medical terminations. So if someone is on a healthcare card or pension, I will bulk bill them. They will then just have the usual charge for the prescriptions at the pharmacy. Some of our challenging patients have been women without Medicare cards, and I can't ask the pharmacy to give them the drugs for free, although I think they might if pushed. But a couple of us have said, look, if we have to, we will waive any fee for those women.
Thank you, Lou. So can I just thank all of the presenters for your cooperation in getting to this point reasonably in time, and now open it up for participation from all of our attendees who aren't on the panel tonight. We don't have a roving microphone, so just remember that you're speaking to us here and project a bit, and I'll call up presenters if we need to do that. So, and please say who you are, where you're from, so that in the spirit of you know who we are, we also know a bit about you. So there are a few questions coming in the course of the presentations. Don't all go quiet on me now. Cathy, did you want to say something?
It was just what Lou was saying about people without Medicare. I meant to mention that we generally don't see them because we're concerned about what the cost would be if they did actually do a DMC. It's not, we would be happy to waive our fees, but the hospital costs can be astronomical, and usually the private clinics will give a single price. Sometimes it can go through their health insurance, so at least they know exactly what they're up for up front.
Questions on costs seem to be pretty popular. Any more explanations that anyone is seeking on that topic?
I just mention it because I think it's a big barrier for women accessing Terminations. We're the gateway health provider in Melbourne. Between our two services, we've done about 230. And we don't charge at all, so they just pay the cost of the prescription. And we have a fertility control clinic and an outreach service in our local town. And a lot of women we find come to us because the cost of the surgical option is a big barrier. So I think in terms of increasing access, the cost is a big barrier, particularly to young teenagers who may be homeless and have no support.
And just so everybody knows, can you explain how you get around the ultrasound cost?
Well, we just refer to our local ultrasound providers and
They both know.
and we can get one within on the day. So
That's fantastic.
we're in Victorian times. I mean, we kind of advocate for our patients. So
I'm familiar with Gateway from my former background as Upper House member for Northern Victoria. It's a great health service. Great to hear that you're helping women in that way. So how do you organise the resources to ensure that women are not out of pocket?
I'm the GP, and these are the two nurses that run in the nurse-led clinic, and so we have funding for a sexual health clinic. So we have 2 appointments between the 2 of us, and I just choose to not bill everybody because I believe that access, cost is a barrier to access. And for non-Medicare card holders, we see quite a few of them from migrant backgrounds.
Yeah, no doubt.
My name's Louise Holland. I'm from Bendigo. I work in Bendigo Community Health Services. And I suppose what's really interesting for us in our model is we have GPs who work in their private GP practices who have chosen to, I suppose, go alone and be perhaps known within the city of Greater Bendigo of being a doctor that you can go to. And we've had a couple of experiences where some GPs are only going to see their current clients, so they won't accept new people to their service just for an MTOP. But we've had a couple of other GPs who are happy to see people from anywhere. But how they receive those people is that they, myself and my colleagues who are women's health nurses and sexual health nurses, we'll actually do a lot of the counselling and the discussion around what needs to happen. So basically, by the time they get to the GP, a lot of that groundwork has been done. So the timely access for that client is served by my colleague here from Women's Health, Robin Elliott, and ours, in terms of doing some of that nurse work that reduces the time for a GP. So generally, they only have that initial consult and then perhaps a follow-up one. So that's just working within an area where there's a really good network between, say, community health and private GPs. And we do have one GP who works in a large bulk billing service who will bulk bill for all the services as well. Yeah. And we have a surgical termination clinic at the Bendigo Hospital provided through the obstetricians and gynecologists from the women's, but the hospital does not provide medical terminations. So that's quite a slightly different context in terms of accessing GPs.
Yes, there's a long journey that Bendigo's been on to get any of those said services. So I take my hat off to everyone who's been involved in getting it this far. Yeah. Anyone else? Cathy.
What drugs do you give?
What drugs? Yes. Just a question for Paul. What drugs you give?
Come up here, Frank.
We tailor our drugs according to the patient's dysmenorrhea, pain thresholds. A standard drug is paracetamol combined with codeine. That's 1 gram plus 60 milligrams of codeine. Plus ibuprofen, 400 milligrams as the standard. If the patient's allergic or contraindicated to NSAIDs or codeine, we substitute tramadol, 50 milligrams times 2, that's 100 milligrams. I think it's really important to adequately address pain, because if it's not addressed, you'll have patients coming back and saying, I have the worst pain, worse than childbirth, and this is going to give the procedure a bad name. We do a pain score when we assess our patients afterwards, our nurse does. 3 is a normal period pain. 4 more than, 5 really bad, 2 less than, and 1 we're worried about. Most patients now who have adopted this pain management say it's a 3. The same has to be done with bleeding. If you don't properly address bleeding, prolonged or intermittent, heavy, by additional misoprostol, which now seems to be the way to go throughout the world. Some people are starting this, and we're going to institute this as a routine. You will have a better result, not just for tablet stat, but we're considering we give the patients additional misoprostol, 10 tablets, because our patients come from rural or remote areas. And if they ring up with heavy bleeding and we refer them to the hospital doesn't have misoprostol for a start, and they mightn't even do a DNC there, they can put a drip up. So these patients need misoprostol, which we give. It's about $10 extra. We're prepared to do that for the best outcome. And just by way of mentioning what we do give our patients, we also give all our patients, a urine pregnancy test, which they do at 4 weeks. So that if they don't comply and don't, we text our patients probably routinely 6 times during the process. And a nurse follows them up, and often you have non-compliance, they won't ring, and we text them, how are you going? And our texts get worse, like, we believe that we are concerned that you are still pregnant, please contact us. And they still don't ring. And I'm sure this is because they think, I've had a good bleed, I know I'm not pregnant, I don't feel pregnant, and besides I've got the pregnancy test. They do it 4 weeks, and of course it's fine. So that's to avoid situations where you have a mid-trimester 16-weeker that you're unaware of it.
Paul, while you're still there, can I ask a question too about the number of requests you're getting, and can you keep up with the demand? Because that's a concern, isn't it?
Well, we get now patients from all over Australia. Newman, Derby, Mcnamee, Mount Isa, places you've never heard of and you can't spell. As well as CBD places, which, as I said, it's rather population-based. Probably more in Tasmania because we're the sole abortion provider there, and if patients ring up, our girls say, well, do you want a medical or surgical? Because, you see, our problem is that people out there don't know that medical's available. We're not allowed to advertise. We've had so many obstructions to our service. You can put a billboard up saying, don't have an abortion's evil, you'll go to hell. But you can't put a billboard up saying, have abortion if you have an unwanted pregnancy. So, yes, we have had enough patients that we couldn't deal with at the start. But now our constraint is that our original computer-based, and you need a lot of logistics in this. The paperwork is just so much that we've got a computer program now that looks after it. So you can follow up the patients and not lost to contact. Our computer program now is such that we need to have a web-based multi-user interface so that our nurses can contact the patients at the same time as their doctors are speaking to them, at the same time as their secretaries are booking the patients in. So that's our first constraint. And the second constraint now is that our telephone service now has to be really a call centre to cope with the patients. And that's the stage we're up to. Apart from now we're in the stage of advertising so that we can deal with the patients.
Thank you.
Well-run call centres are a wonderful thing. Yep.
Hi, I'm Stevens from Research. I just thought I'd provide some information about the work that we've just commenced in Murray PHN and the health pathways. So Murray PHN goes the top of Victoria, right from northeast Victoria, Goulburn Valley, right up to Mildura and down to Woodend. And the northeast sub-region has just started looking at the health pathway in top, and Angela and Catherine and I were there on Monday. Once that health pathway has been completed and the referral systems sorted, which will be a great challenge in actual fact, given the issues around sharing information about providers of both medical determination and surgical determination. That information will then be, the process will be then provided to each of the other 4 sub-regions of the PHN, and we'll also work on the referral pathways and make that available to GPs from the region.
Thank you. And you're sharing that with all the other PHNs?
Yeah.
Very good.
I'll just make a comment, sorry to speak again, I didn't say my name, Vinnie Catherine, it was my name at GP Gateway, about the many GPs that just want to offer MTOP to their clientele. We're in a community health centre, and so we're ideally placed for MTOP because people coming in the door can be coming in for anything they like. So there's a huge amount of anonymity with our service, and we find that probably 5% are referred by their regular GP. So the 95% of women actually don't want to go to their regular GP for their MTOPs. So if GPs are just offering an MTOP service to their existing clientele, they're actually not servicing the need. And I get that there's GPs have a worry and a concern about privacy and whatever else. I don't happen to have that worry. I'm in Victoria with the exclusion zone, so I don't feel concerned. And neither do Angela and our nurses that basically run the nurse-led clinic. So I really feel that limiting it to your own clientele is not the way to offer MTOP in a regional area. And the reason we've just been inundated. We've done so many, and I think it's mainly because patients want to come in to an anonymous service, and it's the same with the tablet. They don't want to let it back to their GP, and they don't want it on their file that they've had their MTOP. So, we've been overwhelmed by how many we've done, and I think it's because patients just self-refer, and they can have that privacy. So we should be encouraging GPs who are willing to do it to offer it to their...
Did you actually actively advertise?
Yeah, we do. We fought pretty hard to do that because we circulated through the Medicare local and all the local GPs, all the local emergency departments and specialists. And that was all that Gateway Board would allow us to do initially. And Lauren and I fought pretty hard to have it advertised because we're not fast, not worried. And we had to go through a risk analysis, and then it went to the board, and now it's on our website. So if you go onto Gateway, it doesn't have anyone's name on it, but it just says that we offer the service. And we're really proud of that, because I think the more we're talking about medical determination in just normal medical care, the less stigma there will be around.
I mean, we might see that response of I'll only look after my own patients might be an intermediary step for some people. They might get their confidence up that way, then talk to someone like you and go, okay. So that's what I'm thinking.
Yeah, hopefully.
Can I ask a question? You're advertising to doctors. How do you advertise to the public?
It's on our website, so we've got a public website.
They've got to go to your website to see.
Yeah.
Yeah.
Well, you can Google MTOP and you'll get a Gateway Health as a hit.
Google have restrictions, search restrictions for advertising in this
It's on our
country.
Facebook page. Do you want
In this country. Google have search restrictions on advertising medical abortion in this country because the Therapeutic Goods Administration enforces that because there is specifically a law that prevents you from saying that a drug is an abortifacient. We've had to radically change our website.
I'll pretend you only do
We've had to radically change our website because of complaints from MS Health advertising their drug. TGA contacted us.
It's unplanned pregnancy, counselling, and termination.
You can't say DMM words. You can't say drug or medication. That's right, because it's illegal to advertise.
Yes, I can happily say as a former MP that there are laws on our statute books, state and federal, that do not serve us well, especially women who didn't tend to make them. Over to you.
Hello, I'm Carl Rico, I'm the General Manager for MS Health. I just wanted to make a point about Google. We've also come across the same issue. We actually contacted the TGA and asked them about the provisions within the Therapeutic Goods Act. They say it's not anything to do with the Act, that it's a decision that Google have made. So we've had some discussions with Google, and it's quite difficult because it appears to be a policy decision that they've implemented, not necessarily a decision that the Therapeutic Goods Administration made. We've spoken directly with them, and we've picked up the quote that you're referring to in terms of the Therapeutic Goods Act, and we've raised that specifically with them. And we've actually contacted them formally, and we're awaiting a response. So, yes,
next
it's
step ideally
interesting.
would be for us to work together to then go to the government ministers and point out.
And as far as advertising goes, you can't advertise the drug because it's against the Therapeutic Goods Act. It's illegal to promote a prescription medicine. You can talk about medical termination of pregnancy, but the difficulty you have is that there are no other brands of medical termination of pregnancy products on the market. So by default, when you talk about medication and you're talking about medical termination of pregnancy, there really isn't anything else. So you've got to be quite careful about it. But you can't promote MS two-step, for example, in the context of the drug name because you are breaking the law in a sense of advertising to consumers. But you can talk about medical termination of pregnancy.
Why was it they could advertise by
They're not allowed to. It's against the law.
No one goes to jail for it.
Yeah, well, it's up to the Therapeutic Goods Administration to actually take steps to prosecute people and organisations that do that. If you're doing a Google search, for example, and you talk about a particular medicine, they understand that it's going to come up. When we were having conversations with the Therapeutic Goods Administration, we raised that point. We said, look, anyone going onto a website browsing and puts in mifepristone, obviously it's going to come up. And they said, well, the intent is not to prevent that because they understand that consumers will be looking for information. It's just about promoting specifically MS two-step to consumers. And as the sponsor, we have an obligation not to do that. Thank you.
Thanks for that information. Now, I'm just aware that we are running down the clock now, so is there anyone, I can see someone at the back who hasn't had a go yet? You can just project a little bit more.
Terribly loud. So, okay, so there's been quite a bit of talk about cost as a barrier and access. So I just wondered what the specific things people have come across in terms of in relation to cultural issues, language issues, and how that might have been addressed in some of the models people have.
the Fertility Control Clinic.
Suzy, you'll need to speak up or use this.
Oh, the Fertility Control Clinic has a lot of its information about both surgical and medical abortion in Chinese and Vietnamese. And we do find that we see a lot of international students. Those coming more from, we'll see a lot from India and Sri Lanka, and usually their English is really excellent. We have a very different population to, say, the Women's Hospital, where I assume that's a bigger issue.
One of the difficulties because we're still in a pilot phase, that we sort of initially decided that we don't have any information other than in English, that we wouldn't actually take people who we felt that couldn't understand English from us. But we have actually started to bend that if the partner actually speaks English. We get an interpreter in to explain the whole process, but it's about the written information afterwards, which we don't actually have the backup for, because it's very hard to sort of remember all the information. So that's the difficulty we've had, but it's something we're sort of going to have to face a bit more in the future.
Cathy, could I say, we've found that a great problem, because you might have the time to have an interpreter on the phone, but when they ring up bleeding heavily at 10 o'clock at night, you can't deal with it. So one of our criteria is they have to not only understand English, but not only speak English, but understand it. It's a real problem.
That was an excellent question, and one that worries me quite a lot, Louise, because I think at the Women's Desk we can get translators and interpreters and work with them. We always try that the support person at least would be able to speak, so they were with them. But I don't think anyone has ever really explored the experience of Indigenous women around abortion properly, and what their emotions and feelings about medical abortion might be. And I think that's something that it worries me, that I don't know about that. I don't know enough about it. I don't know how to approach this with Indigenous women or Indigenous communities yet. I'd be interested in other people's comments. Some of the rural workers might have more to say on that.
I can comment that one.
Yeah, do, please.
So I'm Laura from Gateway Health. So we've been working quite a lot with our local Aboriginal health services about trying to get them to engage into their service. Which is our big practical to try to get topic share service. Yeah, so sharing protocols, taking referrals. I think one of their biggest concerns is around not necessarily the community's perceptions, but more so the health workers' perceptions and what information the health workers confidentiality as well, because it's a small community, the Aboriginal community. In a dedicated Aboriginal medical service, everybody does know each other, and if you're coming in for that service, so there's issues. We actually have a refugee clinic within our same gateway, and we use interpreters all the time, and we wouldn't use anybody to speak English as everyone's on the time.
You wouldn't?
We wouldn't.
No,
we have used an interpreter.
I think it's important to say that GPs can access telephone interpreter service at no charge. So it's a very accessible service, and once you're used to using it, it flows really well.
So at this point, I'm going to encourage people to perhaps move to the refreshments and continue these conversations. We've got a lot of people in the room tonight, and areas of action that are required, and a capacity to organise around getting something done on those issues, because after all it was all about access and where we've come from, where we aspire to get to, and addressing barriers to access, including for communities where the barriers are much greater. So I'd encourage all of you to think about ways of doing that into the future. Online tools are wonderful things in this day and age. and governments can be helped to make decisions about changing legislation and policies. Hi, Louise. Governments can be helped to make decisions when communities express their views clearly and in great numbers, and online is a really effective way to do that and to reach young people, a whole range of people who are not going to be reached in other ways. So can I thank particularly our panellists who came along to contribute, thank everyone who came along to be part of the audience and contribute. Can I particularly acknowledge Rita Butera and the team from Women's Health Victoria, particularly our very own Dr. Amy Webster for all of the work that's been done. And as was mentioned, the plan is to have another forum later in the year, and you'll hear about that when that's in the planning. So thanks, everybody.
Great to hear more about your service. I guess it's